So this is a little bit about who I am, just so you know, like, yeah, just so you know who's talking to you. So like Vanya said, I've passed my finals, so I'm doing a master's at the moment. So this is me swimming at New Brighton Lake, which is near me. So yeah, I like doing like open water swimming. I'm just back from swimming at the docks in Liverpool, which if anyone's in Liverpool, you're always very welcome to come along. These are my two cats, Maple and Marmite. And I like doing like baking, or what else do I do in the spare time? I quite like cooking, running, cycling. So yeah, so this is the plan for today. I'm going to try and keep to time because I know everyone's tired, everyone's busy, everyone wants to have their tea. So a quick introduction and like what we're going to do, and then go through these things, 5 minutes each. It's not a lot of time, but for Liverpool Medical School finals, I don't think you need to know a lot. And then we're going to do a few questions at the end. Hopefully that sounds good. If you have any questions as we're going through, by all means stop me or put it in the chat. I can see messages to everyone in the chat, but I can't see messages to just me. So yeah, if you have questions, just put it as like a message. I'm going to try and keep it fairly interactive, just to keep it like a bit more engaging. So yeah, any ideas? That sound. So these are what I thought were like important things to go through. So by the end of this, I want us to be able to understand and explain serious and or common psychiatric emergencies, understand the management principles and treatment options, and apply the knowledge to clinical scenarios. So this, like Vanya said, is all based on UK guidelines. So I've finished 4th year, I'm not a clinician. So if you have local guidelines, then go with them. And I'm in Liverpool, so I've put some like crisis resources at the end, which are really good for Liverpool. Probably not good if you're in anywhere else in the UK or indeed abroad, but there's probably fairly similar stuff where you are. Okay, so if anyone can give me any ideas of what a psychiatric emergency might be, can you think of any? Because before I did this presentation, I was not sure like how to define it. So what might a psychiatric emergency be? Suicidation with high intent, yeah, perfect. Overdoses, yeah. I haven't covered those, but yeah. Ligature, good. Hanging, patients out of control, manic episodes, yeah, good. So everyone's got the idea that it's like an acute, yeah, so NMS, self-harming, yeah. So these are all really important things. I've defined a psychiatric emergency as like something that is immediately life-threatening, has like an element of like acute behavioral disturbance, and is recognizable and treatable. So overdoses are a medical emergency, but they might not be necessarily like a psychiatric emergency, if that makes sense. So obviously really important to know how to treat your overdoses, but I haven't covered that. Suicidal ideation I've covered. Ligature and hanging I haven't covered, but they're in terms of like BLS, and also hopefully you wouldn't be expected to deal with that as like an F1 here. And I haven't covered manic episodes because that is like that's a psychiatric thing, but it's not necessarily acute. Okay, so we're going to go through neuroleptic malignant syndrome first. So someone mentioned it before. Does anyone know like what this is? Have people heard of it? Adverse reaction to antipsychotics. Adverse reaction to antipsychotic use. Perfect, good. So it's a life-threatening, idiosyncratic reaction to neuroleptic drugs. Yeah, so it's oversensitization, sonography, dopamine, good. So what does it mean by it's idiosyncratic? Anyone know? So it means that it's like adverse, rare, and unpredictable. So you can't say like a certain person, yeah, good. So yeah, so you can't say a certain person is going to get this. So with some drugs, we can say, oh, if you have this gene, like you're most likely to get this, or if you're from this background, then you might get the side effect. But with this, like it's very hard to know. And it can also occur, oh, I can't see, let me see if I can use this. Hey, there we are. So it can happen like at any time. So obviously a lot of drugs, if you start the drug and you don't get side effects, or at least my, like, the way I would think about it, would think, oh, the person's not going to get side effects. But But with this, it can happen at any time. So you could have been on antipsychotics for a long time, and you could suddenly get neuroleptic movement syndrome. So, it's not moving. Okay, so what causes it? So someone's mentioned antipsychotics before, but you basically get so a central dopamine receptor blockade. So that means that there's not enough dopamine in the body. So it's typically first generation antipsychotics, like haloperidol, which is like most commonly used in the UK, or not most commonly used. It's the only one I've seen used in the UK, in terms of like the first generation antipsychotics. How common is this? Does anyone know? Has anyone seen it? No, that's not like the most scientific method. But... So no, we said rare. Yeah, pretty rare. So I couldn't find very good data on it, to be honest. We'll come on to that in a minute with recreational drugs. So you're right, you're thinking of something else. Oh, someone's seen it. Okay. But it's not that common. So I found the data's a bit rubbish. So it was something like between 0.62 and 3.2% of psychiatric inpatients can get this. So if you think about actually like the percentage of the population who are psychiatric inpatients is not huge. So yeah, it's pretty rare, but it's one of those that you need to recognize it, if that makes sense. It's quite dangerous if you don't treat it. Oh, why is this slide not working? Okay, so how does it present? So there's this and serotonin syndrome, which are like quite similar. Rigidity, fever, autonomic instability. Perfect, Eleanor. So we said tetrad of lead pipe rigidity. Good. So if you think of like, effectively it's sort of Parkinsonism because you haven't got enough dopamine. So you have a fever, you have an altered mental status, which is really significant. You get a fluctuating BP because you've got this autonomic instability. So the temperature set point isn't quite right. You get lead pipe muscle rigidity, which is really important. And you can get rhabdo because if you're contracting your muscles the whole time, then eventually your muscles are going to break down. And that's also the reason you get the hypothermia, because it's like you're contracting your muscles so much that you've got so much respiration going on that you get hypothermia. Anyone know how you treat this? Naturally, yeah, good. So you're gonna, yeah, good. So Carol said stop the antipsychotic, which is really important, yeah. So you're gonna stop that, but also you have to bear in mind if someone's on an antipsychotic, they probably need to be on an antipsychotic at some point. But yeah, you stop it for at least 7 days, or 5 days, sorry. And then, yeah, you can give bromocriptine, which is a dopamine agonist. You can give dantrolene, which is a muscle relaxant. And you also need to make sure it's recorded on the patient's notes. It's like an adverse reaction. So we're going to talk about serotonin syndrome, which I think might be what you're thinking of. But I think it can also be caused by metoclopramide, but I'll double check for you. Is that okay? Sound. Okay, next one. Hypertensive crisis. Has anyone heard of this? And know what like class of drug it's associated with? So, first of all, like, what would you call hypertensive? Because it's really important to know, like, what we're defining from that. Hypertension with organ dysfunction? Yeah, arguably. More. So 140 over 90. Yeah, so more than 180 systolic or more than 120 diastolic. And someone's written MAO inhibitors. So yeah, perfect. Is this a psychiatric issue? It's called like a psychiatric emergency. So it's caused by like psychiatric drugs, if that makes sense. So yeah, so hypertension, for this purpose, is like severe hypertension is defined as more than 180 over 120. So what can cause this? And someone said like MAO inhibitors. Good. And they work by inhibiting the breakdown of neurotransmitters at the presynaptic neuron. Sorry, I'm just going to check that up. So there's certain foods, I put it up, but hopefully no one's looked. So there's certain like foods that can trigger this. Cheese, yeah, good. Any others? Particularly like aged cheese, apparently, like Parmesan and stuff like that. Think of like nice foods. Aged wines, yeah. Wine, yeah, red wine particularly, I think. Anything else? Meat, yeah. Like cured meat, supposedly. So think of like a really nice charcuterie board or like a really nice picnic or something. So that's the kind of things that can cause this. And also chocolate. So this was, I don't know, this may not be very useful, but I found it quite interesting. So it was discovered by like a chemist. A pharmacist who noticed that his wife got a really bad headache when she ate cheese and she was on a MAO inhibitor. So yeah, this was like a first reaction that was noticed by that. So, does anyone know why this happens? Tyramine, good. So what about the tyramine? So yeah, basically you get like, it's not broken down and it displaces other neurotransmitters. So then you get norepinephrine release, and then that triggers like the hypertension. So what might be some side effects of like a severe hypertension? Do you think? Yeah, intracranial hemorrhage. I presume that's what you're saying. Ischemic stroke, potentially. Anything in the eyes that you can think of? Headaches, blurred vision, palpitations, yeah. So like all of these side effects. And like the ones that you see in the eyes would be like flame hemorrhages. So you might see papilledema in like increased intracranial pressure, but you'd initially see like flame hemorrhages if there was like high pressure. Does that make sense? Does anyone know how you manage this? Say it's like quite severe. ACE inhibitors? I mean, you could. Labetalol, potentially. These are all like very sensible suggestions. So, I didn't know this. So basically, when you first start someone on this medication, yeah, you need to tell them to avoid like eating cheese and wine and meat and stuff like that. And then you can treat it with phenytolamine, which is an alpha blocker. And I found some case studies where they did sublingual nifedipine. But yeah, the mainstay of treatment in the UK is this phenytolamine. Okay, everyone still with me and happy? Okay, we're going to go on to serotonin syndrome. So, what is serotonin syndrome? Anyone know? Like, how would it present? Or like, what's the pathophysiology? So yeah, too much serotonin, effectively, yeah. Who are the sort of people who are at risk? Yeah, so it's similar to neuroleptic malignant syndrome. Diarrhea, flushing, good. Tachycardia, dilated pupils, that's a key thing. Sweating, loss of coordination, increased reach. Yeah, good. People on sertraline. So what kind of so that's like an SSRI, isn't it? Any other classes of drugs? Yes. Those on MAO inhibitors and SSRI at the same time. Yeah, good. More of a hypertonia. We'll talk about that in a minute. So yeah, these are some of the drugs. So it makes sense, the ones which are like obviously serotonergic or have like serotonin in the name, or like psychiatric drugs. I think those are the ones that are easier, or at least I will find like easier to remember. I'm just gonna move my picture. So we've got SSRIs, SNRIs, MAO inhibitors, and tricyclic antidepressants. But there's also, I don't know if it's common elsewhere, but a lot of like older women I found in the UK take St John's wort, which is like a herbal over-the-counter thing. So that also, because it's not like regulated, you don't know the level of stuff in it. So it's a medication that also has like lots of interactions. Also triptans, ecstasy, cocaine, tramadol, and metoclopramide. So there was like a safety alert issued in the UK last year, maybe the year before. So a lot of patients are on tramadol and an antidepressant, like an SSRI or an SNRI, and it'd be very easy to like start them on something else, and then like not realize. So how does it prevent? Someone's already said tachycardia, dilated pupils, sweating, loss of coordination, increased reflexes. Yeah, so you basically get, so it's like more of a spectrum on this. So some people present with like just a bit of tachycardia or like a little bit of the temperature, but you get hyperreflexia, tremors, and seizures. So it's not necessarily like a hypotonia, but it's like rigid, like more reflexes and like moving a lot more. If that makes sense. So it's not like they're floppy, but it's not like they have lead pipe rigidity. Yeah, and you also get like an altered mental status and the hypothermia. So, anyone know how you manage this? Benzodiazepine? Good. Yeah. Stop the drugs? Yeah. Supportive? Yeah. So, does anyone know like what supportive measures you might be able to give? So, I saw someone with this in like our fluids, yeah. And if often like this will present with like mixed overdoses. So if someone has taken quite a lot of paracetamol and you don't want to give them more paracetamol to bring the temperature down, you can put like ice packs under the armpits, or like areas where there's like good blood flow. Yeah, fluid. So you stop the medication, you can give benzodiazepine. Obviously, if someone has like quite a mild like form of this, then you don't necessarily need to give them like loads of benzodiazepine cooling, and you can also give a serotonin agonist if it's really bad. So, what is the difference between this and neuroleptic malignant syndrome? Because they seem pretty similar, I think. So, can anyone point out the difference? Oh, hi. So, CK elevation, the onset. Oh, is someone trying to say something? I can't hear you very well. Onset, good timing. Trigger, yeah. So, like, if you know someone's had access to like neuroleptics or like serotonin, good CK elevation, that's like a key thing. The pupils, someone mentioned before, so you wouldn't see anything in, or you see like normal pupils in neuroleptic malignant syndrome, whereas in serotonin, there's a constant sound of water. Does everyone else have that? Oh, okay. Let me see. Is that better? Any better? Not really. I think someone's mic is on. Let me see it. Okay. Can you hear me now? Yeah, okay, right. We might just have to cope like this. Sorry, might be my shitty head. So we were saying about neuroleptic malignant syndrome. So in serotonin syndrome, you in these conditions, isn't there a white blood cell elevation? Yeah, good. Do you know which one? Hello? Someone gonna answer? Yeah, it is a difference. Yeah, okay. So in serotonin syndrome, you see increased reflexes, mydriasis, and a tremor. Whereas in NMS, I'll just say it like that, you see decreased reflexes, rigidity, and normal pupils. And I've got which one you see the white blood cell elevation in. I'm pretty sure it's neuroleptic malignant syndrome, but I'll make sure I put it on the slide and get back to you. Sorry, it's a bit of pain. I wrote it down in my notes, and I've lost my notes. Okay, DT. Who gets this? Who gets DT? People with alcoholics, yeah, good. Withdrawal patients, people in deprivation, anyone but more elderly alcoholics, yeah. So I think a key thing to remember is like people won't necessarily tell you that they're in alcohol withdrawal. So before I was a medical student, I worked in a care home, and we had a lady come in for respite, and she obviously drank a lot at home, but no one really knew. And about 3 days in, she was really friendly, but about 3 days in, she got really like paranoid, and we couldn't work out why. And she ended up going to hospital, and they're like, "Oh no, it was like TT." So she was an alcoholic, which no one knew about. Yeah. So how does it present? Tremor, yeah. Confused, good. Yeah, hallucinations, that's like a key thing. What type of hallucinations? Spiders, yeah, that's like a very typical one. So tactile. Lilliputian, I don't know what that means. Do you want to tell me what that means? It sounds interesting. So like worms, snakes, yeah. Visual hallucinations, lots of small things, small people, good. So, perfect. Aggressiveness, yeah. Particularly if you thought you see small animals and small people and you find it amusing. I didn't know that. I'll write that down. That's really interesting. So yeah, you get like an acute confusional state, shaking. It's normally like 2 to 3 days after stopping drinking. Sweating, hallucinations, which are often visual or tactile. The symptoms are worse at night, which sort of fits with the picture of like a delirium. So it's like fluctuates. Fever can lead to seizures and can lead to death. So withdrawing from drugs is obviously like quite horrific, like heroin or whatever, but you wouldn't tend to die. Whereas this can like people can actually die from this, which is why it's quite dangerous for alcoholics to just stop like drinking cold turkey. So the key thing which I hadn't really thought of but is really important is you need to rule out other causes of acute confusion. So yeah, these are just like some of the causes that you could have in like someone with an alcohol dependency issue. So it would be unsurprising if they had a bit of pancreatitis or an alcoholic hepatitis or electrolyte dysbalance. So neuroleptic malignant syndrome, I've just remembered, is the one where you get white blood cells. So how do you manage it? Oh, sorry, E2H is alcohol. Sorry, I should have put that. So yeah, does anyone know how you manage it? Blood boxide, yeah, good. That's like a type of benzodiazepine. It's like a long-acting benzodiazepine. Thiamine. So you would give thiamine, but that's not necessarily to manage like the DT. It's to manage like the Wernicke's encephalopathy afterwards. But yeah, you're right. Cabernet, yeah. So that's like the brand name, isn't it? Good. Admit them, yeah. So these are not people who you just want to be like, oh, they're fine. Like I'm not too worried about them. These are like people who you might be a bit concerned about. Lorazepam therapy. So you give them a benzodiazepine if they are or aren't agitated. You can give them carbamazepine as well. So there's lots of different treatment regime. If the hallucinations were really severe or distressing, you could consider haloperidol. But as we've done before, not necessarily like the nicest drug. But yeah, if you do have to give them, then you can give them that. Okay, acute dystonia. Anyone know what this is? So like sudden contraction, extrapyramidal, good. So if it's like sudden, painful, repeated contraction, it's normally in like the face or the neck. So it's an extrapyramidal symptom of mainly antipsychotic use. Torticollis is like a good example, yeah. So that's like obviously in the neck. What causes this? Tongue protrusion, yeah, we're going to talk about that in a sec. So quetiapine, yeah, something like I haven't heard of quetiapine causing it, but you probably are right. But it's normally first generation antipsychotics, haloperidol, but also metoclopramide and chlorperazine. So does anyone know what we often use those for? Oculogyric crisis, yeah, it's another example. So what are metoclopramide and chlorperazine? Nausea. Yeah, good. Okay. So some people have like already mentioned like how it presents. So they've said like torticollis, so the contraction of like the neck muscles, tongue protrusion, sustained or repetitive muscle contractions, which are painful. And as opposed to like before, it's often within like 7 days of starting medication. So an example is like an oculogyric crisis. So what's the like typical way the eyes deviate? Upwards, yeah, good. So if you've seen pictures of this, quite striking. And also you can imagine it's pretty distressing for patients. How do we manage this? Percent. 7 out of 7 is like 7 days, sorry. So yeah, you want to like stop the medication. Yeah. And then you can also treat it with like anticholinergics to balance the cholinergic and dopaminergic activity. And then benzodiazepines can be useful if it's like refractory. So a key thing I wanted to mention about this was tardive dyskinesia. So does anyone know what that is? Do you know anything about it? It's a later presenting EPS, restless facial, so lip smacking and other facial tics. And it can also like involve the arms. So often with people who are on antipsychotics, and the problem with this is that it's quite, if you have like tics in your face, it's quite difficult to like, because it'd be like embarrassing or like difficult to get on with daily life. And one of the problems is even if you stop the medication, if you don't stop it really promptly, the tics can continue. So it can have a huge effect on people's like livelihoods and like psychosocial stuff. So it's these things are like a really important thing to watch out for and to warn patients about as well, that they could like get these symptoms. Okay, so just the last bit on suicidal thoughts. So obviously like pretty anticholinergic options. Do you mean like medications? I'll be honest, I don't know. I just anticholinergic. Sorry. I think in terms of like what you need to know at Liverpool, I think you need to know that like you would just give an anticholinergic. To be honest, I think effectively what I'd be worried about is recognizing these things. Because as an F1, it's like a very junior doctor, you would no way be expected to treat these patients. But someone has very kindly informed me that you can use procyclidine. Perfect. So in terms of like suicidal thoughts, obviously quite common, and you quite often see them in like a lot of patients. So, well, when would you like be particularly worried? Active plans, fine lax, yeah, high intent plans. Sad persons. I've not heard this mnemonic before. Patient suddenly feels better, gives things away. Yeah. So there was a patient on a ward he was a psychiatric outpatient. And we knew him, and he started giving like his dog away to someone, and it just made everyone like pretty nervous. Because it's like major plans. So in terms of like risk factors for like the patient, like demographic risk factors, so like a previous attempt is really worrying. So men or women, family history, yeah, or like even just knowing someone who's died by suicide, men. Good. So these are like some of the key things. So yeah, like men, single and divorced, young or middle-aged, elderly with multiple comorbidities or like chronic illness, past attempts, someone mentioned already, substance misuse, so like alcohol excess, being recently bereaved, knowing someone who died by suicide. There will be in 2 seconds, Mohammed. Yeah, and also like trans people are particularly at risk. Yeah, so these are like signs that I guess you might see afterwards. So if there was a plan in place to not be found, if they left a note, made attempts to not be discovered, or sorry, if there's a plan in place, as in like they say like, oh, I'm going to go and do this. If they thought the attempt would be lethal, so that's like a really key thing to ask. So someone who takes 2 paracetamol or 4 paracetamol, obviously that's not enough to make someone die. But if they thought that was going to kill them, then that's still an attempt that should be taken really seriously. If that makes sense. And if people are like not regretful after they've been discovered. So, in terms of support, what are your options? And I appreciate this will vary quite a lot depending on like where people are. So what could you do to help these patients? Emergency detention, yeah. So yeah, like what I would, it depends where I was, but obviously like you wouldn't be managing as a medical student and you wouldn't be managing this as like an F1. But yeah, so the options for like the crisis team. So obviously voluntary detention is much better than like involuntary. So if you can convince someone to come to hospital, that's much better than having to like section them. And obviously you wouldn't be doing that as an F1, you need like 2 psychiatrists. S136, yeah, if they appear like dangerous to themselves or others. But yeah, the mental health team liaison referral. So you do like a risk assessment is your key first thing. Because a lot of people sadly will get suicidal thoughts, but that doesn't mean that they have to. If everyone has suicidal thoughts was admitted to hospital, then we wouldn't have any space in hospital. So you're not making decisions by yourself, and you're contacting someone who is like much more senior than you, so it shouldn't be on your shoulders. And then in Liverpool, I don't know if other people knew about this, but there's a really good service where they provide support. It's called like a mental health cafe from 6 p.m. to 1 in it's right near the Royal, and that's also the crisis number that you can ring. So yeah, we can't like detain everyone, but yeah, it's in terms of like making a risk assessment, asking about like risk factors, asking about protective factors, and like making a plan with the patient. So we're going to quickly do the scenario, and then I will let you go. So Tom is 26, found by his ex-partner following an argument. He wasn't expecting her to come in the house and left a note. He's a known user of alcohol and cocaine. His brother's on antipsychotic medication. His dad takes Maui's, and his sister's on an SSRI. There's also paracetamol in the medicine cabinet. He's taken a mixed overdose, which is pretty common, but you don't know what it contained. So on examination, his pupils are dilated and he looks unwell. He's tachycardic, diaphoretic, and breathless. His foot has 5 beats of tonus and he's hyperreflexic, and his temperature is 39.2. So what is the likely diagnosis? How could you manage Tom, and what in his history concerns you about his future risk of dying by suicide? Yeah, so serotonin syndrome, good. Perfect. How would you manage this? Yes, you want to admit him, yeah. He's quite poorly. Anything else? Alpha, yeah, you could argue, depending on like his, yeah. So you do like an A to E assessment. So that would be your first thing. Blood paracetamol level, LFTs. Yeah, these are all like sensible things to do. He's quite warm. What might you be able to do to support that? Yeah, so you could call him. Good. Yeah, you could potentially do a stomach washout. Depends when you last gave like the thing. When he may or may not have taken the overdose. Cold IV fluids, charcoal. Good. And then, hello? Okay, Sam. And then what in his history concerns you about his future risk of dying by suicide? So he's left a note, good. And he's got a history of substance abuse. Family history, yeah, potentially. He's a man, yeah, he's a young man, which is concerning. Yeah, and there's like notes missing. Yeah, good. I feel like you guys that didn't think she would come. Yes, that's a key thing. He's not done it to. He's not done it. He's not wronged someone and said, "I'm going to do this," and then he's done it. He's made plans to like not be discovered. Yeah, and he's fine stuff. So this is just like a quick refill, so you can give like the serotonin agonist for Chetine. Okay, so Sally is a 58-year-old lady who was diagnosed with schizophrenia 20 years ago. She's engaged with services on and off for several years, and she's just started to drink alcohol regularly, consuming up to 100 units a week for at least 2 months. She's admitted following a fall down. Yeah, of course you can have the slides. So she's admitted following a fall down some stairs, and then after 3 days, she's normally like sound with you. She becomes intensely suspicious of the nurses and doctors on the ward. I'm not very imaginative, so I said she saw spiders. So, what is a likely diagnosis? How could you manage Sally? Yeah, perfect. And do you think her hallucinations are due to schizophrenia or another diagnosis, and why? So everyone said DT. Good. Alcohol withdrawal, yeah. Could be both, arguably, yeah. Yeah, A2 assessment. Chloride epoxide, good. Yeah, potentially lorazepam. Benzo, yeah. So, schizophrenia is most likely auditory hallucinations. Yeah. So, if you have like visual or like tactile hallucinations, or like gustatory, I can never say that. Like you taste stuff. That's often like a disease like in the brain, as opposed to like I guess it's almost like a neurological thing rather than a psychiatric thing. And obviously these things are like highly linked. But yeah, if she hasn't had a previous history of tactile hallucinations, then it's likely the alcohol withdrawal is causing me. And also, like, if she got new hallucinations and you treated this and they didn't go away, then that would sort of give you a bit of your answer. But regardless, if she is drinking 100 units a week and she suddenly stopped drinking, then she needs some form of like benzodiazepine or something just to tide her over. Does that make sense? Good. Okay, does everyone feel like we've covered these aims? And have you, hopefully we've covered everything. Have you got any questions that I may or may not be able to answer?